Everyone, I'm Andrea Duarte from the Connecticut Department of Mental Health and Addiction Services, Prevention and Health Promotion Division. I'm happy to have you all here with us today and to unveil a new action line. Our folks in the evidence-based practice division in the United Way have worked very hard to get this together. And I've been on the planning committee as well over the past 2 years. So it's been a long time coming, and it's finally in full scope, I think, across the state. So they're very excited to share with you today. And we thought this would be a wonderful opportunity to connect with the different regional behavioral health action organizations and folks that are connected to them at the local level to really just give you a good sense of what this is all about so that you can help promote it to the people in your communities and ensure that the information is accurate, because we definitely have been hearing varying kinds of information passed to us, and some of it is true, and some of it, we need to dispel misconceptions. So we're very happy to provide this information for you today, and hopefully you can push it forward. We have wonderful materials to share with you as well that we'll be able to get out through the regional behavioral health action organizations and your agencies. And with that, I would just like to introduce our speakers today. From the Office of the Commissioner, along with me. On the other side of the building, though, although we've been teleworking most of this year, is my colleague Dana Began, who's a behavioral health program manager like myself. And she's in she's in the evidence-based practice and grants division. And at the United Way, we have the director of 211 Contact Center Operations, Wendy Caruso. So thank you both for being here and presenting the new action line today.
Thanks, Andrea. Dana, do you want to share your screen or the PowerPoint?
Can folks hear me? Okay, great. And you can see my screen?
Yes, we can now.
Perfect. Okay. Sorry, I got actually booted out for a brief second there, so my apologies. But thank you all for joining us this morning. We are very excited to be presenting on the action line. We're very excited to have it and that it's been fully launched. So I am happy to be presenting with our colleagues at the United Way on this today. What we will ask is, Andrea, I don't know if you said this because I got booted, but if you wouldn't mind just holding your questions until the end or typing them in the chat, and we can go through the chat at the end of the presentation to see the questions that are asked. So if that's okay with folks, then we will get started. So,
excuse me, Dana, I did not
yes.
say that, so thank you for saying that. I also just want to ask folks, we don't have a way of taking attendance other than you putting your name and the organization that you represent into the chat. So if you could also do that, we'd greatly appreciate it. Thank you.
Great, thanks. So our action line, just to start off with the name, is ACTION is an acronym for the Adult Crisis Telephone Intervention and Options Network, which is definitely a mouthful, which is why we call it the action line for short. But we did want a name that would indicate, first, that it's an adult crisis telephone line, and second, that it isn't just for individuals who may need to go to the hospital or to a behavioral health provider, but that there are options. There are other options other than the traditional, what we might think of as responses to crisis care. So that's one thing that I wanted to note, was that we wanted to have that in the name, and that was an important component of the name. So today, this presentation will essentially be providing a description of our Demas and Demas-funded mobile crisis teams and our crisis intervention teams, and we'll be discussing what those are. We'll talk about the process that was involved in looking at redesigning our mobile crisis system and the ongoing efforts that continue to happen and that we're involved with in really examining and redesigning our crisis care system. And obviously the development of our adult crisis call center, the action line, and what it is. We'll go over data and marketing materials and the surveys. And then we'll also be providing additional resources and contacts. So I will be presenting on the first two bullets, and then I would turn it over to my colleagues at the United Way to present on the action line itself. So what are mobile crisis teams? I'm sure some of you are familiar, but some of you may not be, but our adult mobile crisis teams that we have in Demas are for adults 18 and over. We do have a total of 18 mobile crisis teams throughout the state, 6 of which are out of our state operated local mental health authorities, and 12 of which are through our Demas funded private nonprofit organizations. But we do cover the entire state, and each area has its own mobile crisis team that they have available to them. The mobile crisis teams provide various levels of support, from telephone support, where a person in distress may call a mobile crisis provider and just say that, you know, they're in need of somebody to talk to, and the person in distress may be relieved through the telephone contact by the clinician who is at the other end of that phone. Also, as the name says, our crisis clinicians will go mobile, so the person may request for a clinician to come out to where they are, whatever location they might be at, whether it's their home, somewhere in the community, a church, a park, wherever it might be. Our licensed clinicians will go out into the community and meet that person where they are and provide support to that individual. It is a multidisciplinary team, which is comprised of licensed social workers, counselors, nurses, mental health workers or case managers, individuals with lived experience to provide that peer support. And we also do have professionals that are familiar with substance use and addiction, psychiatrists, and psychologists. So it is a very multidisciplinary team. And it is a specially trained team of individuals, and they do receive extensive training on doing suicide risk assessments, prevention and post-vention efforts, identification of recovery and community supports, because that is a large part of what we want to do, is to be able to connect people to resources and recovery supports in their community, not just to refer them back to the traditional behavioral health. If that's what they need and that's what they want, then absolutely we refer them to behavioral health supports. But we also want to make sure that we're making the appropriate connections for them in their communities that will be beneficial to them. And we also do collaborate extensively with local and state law enforcement. And as you might expect, given the recent nationwide events that have been involving law enforcement, there has been an increased collaboration and work with local and state law enforcement and our mobile crisis teams to really partner to intervene appropriately. And many calls that the police are asked to become involved with are really better addressed through mobile crisis clinicians. And our local and state law enforcement have been excellent partners in identifying and recognizing when those situations necessitate a call to the mobile crisis team and to have a clinician come and work with the individual and not law enforcement. So we've been very fortunate to have some good partnerships with our local and state law enforcement. Speaking of law enforcement, we do also have crisis intervention teams throughout the state, primarily located in our 6 state-operated local mental health authorities, but there are a few private nonprofit organizations, CHR is one of them, that also has a crisis intervention team. And what crisis intervention teams are is it's a model, a best practice model that originated in Memphis, Tennessee. It's really a police model, not as much a clinical model, but it is a model that's intended to divert individuals from incarceration, arrest, and hospitalization, and to promote safety of the individual in distress. So it's primarily training that's designed for law enforcement. However, Demas does contract with the Connecticut Alliance to Benefit Law Enforcement, CABLE, and CABLE provides intensive training to local and statewide law enforcement personnel, as well as Demas clinicians. So we really strongly encourage, and we do want all of our mobile crisis clinicians and mobile crisis supervisors to participate in these CIT trainings, again, to create that collaboration, that rapport, and that communication between mobile crisis clinicians and law enforcement. And it's working out very, very well. CABLE has been providing these trainings for quite some time. I believe they started in 2009 with these trainings. And when our Demas funded and Demas operated clinicians attend those trainings, they are really making some great connections with law enforcement, and law enforcement is learning from clinicians, and clinicians are learning from law enforcement. And it's a really nice partnership in understanding each other and the different backgrounds and interventions that we're coming from. So that's been an excellent partnership. So every mobile crisis team in the state does have at least one CIT trained clinician who works collaboratively with the police departments. That does not mean that if a mobile crisis clinician is not officially CIT trained, that they don't work collaboratively with the police. They absolutely do. But obviously, given staff turnover, we want to make sure that all mobile crisis clinicians are CIT trained, but certainly any mobile crisis clinician can work collaboratively with the police and do work collaboratively with the police. When needed, CIT clinicians will respond to crisis calls along with the police and vice versa. So CIT clinicians as well as mobile crisis clinicians will receive calls from the police asking the police, the police are asking the clinicians to join them on a call that they've received, and vice versa. The CIT and mobile crisis clinicians can also reach out to the police and ask them to join them on a call if they feel that that might be necessary. That's not what happens all the time. It's certainly only as needed. And again, it's working out well, and the partnership is working out very nicely. State-operated mobile crisis teams, as well as nonprofit mobile crisis teams, have designated CIT clinicians, which I mentioned already. So as you can see here, there's the map of Connecticut with all of our 5 different regions highlighted in different colors. And this essentially gives you a sense of what LMHAs have a mobile crisis team in each of the different regions. So in Region 1, Southwest Connecticut Mental Health System in Stamford and Southwest Connecticut Mental Health System in Bridgeport have mobile crisis teams. Region 2 has BH Care, Bridges, Connecticut Mental Health Center in New Haven, River Valley Services, Rushford, and South Central Counseling Services. In Region 3, we have Southeastern Mental Health Authority and United Services. In Region 4, there's Capital Region Mental Health Center, Community Health Resources, Community Mental Health Affiliates, and Intercommunity. And in Region 5, we have Danbury Hospital, which is affiliated with the Western Connecticut Mental Health Network. And then we also have the Western Connecticut Mental Health Network in Waterbury and in Torrington. So those are all of the mobile crisis teams and LMHAs in each region. So hopefully that's a helpful diagram. The mission of mobile crisis teams is to provide persons in distress or crisis immediate access to a continuum of crisis response services of their choice. Again, this is where the options come in, and making sure that we're providing services and supports that are appropriate to the individual and what they're looking for and what they're needing. So these could include mobile crisis services, peer support services and community supports, and involvement of families, postvention activities, and making sure that we're supporting person developing meaningful sense of belonging in their communities. So again, really trying to offer those community supports as well as behavioral health and substance use supports. Mobile crisis teams, these are essentially a summary of services and supports that the mobile crisis teams do offer. As I mentioned, they do a significant amount of outreach into the community. They are very mobile. That's why they're called mobile crisis teams. The majority of their work takes place out in the community, and they will provide education out in the community, whether it's to the person who is in distress or the person's support network, their family, the individuals that they live with, whoever it might be. They're supporting those individuals as well. They are doing risk assessments and evaluating the needs of the individual. They provide telephonic support, and oftentimes the individual in distress can, receive that telephone support and feel better after just talking to somebody on the phone. When and if there is a critical incident, they will work with the team on debriefing of that incident. They definitely provide information and referral. Again, sometimes people are calling the mobile crisis teams just looking for information and resources in the community. So our mobile crisis clinicians provide that support and information. We do follow-up after we go out and do a crisis evaluation or an assessment. We do follow up with that individual within 48 hours is the parameter to see how that person is doing, if they need any more support or intervention. So we do follow-up. We offer peer support, so individuals with lived experience. We offer that support. Crisis and safety planning, and prevention and postvention efforts as well. So back in October of 2017, a work group was formed within Demas called the Demas Mobile Crisis Work Group, really looking at analyzing our current mobile crisis system of care and identifying the areas in which there were service gaps or challenges, and really just trying to identify the best ways to improve upon our crisis care system. So this group was formed in 2017, and it was out of the Demas Office of the Commissioner, and it included staff from the Evidence-Based Practices Unit, Statewide Services Division, Forensics Division, Prevention and Health Promotion Division, the Medical Director's Office, Fiscal, and we also had a state-operated CEO as part of that work group, and the Yale Program for Recovery and Community Health, also known as PERCH, and the Demas Assistant Director of Recovery and Community Affairs. So all of these departments and divisions and agencies were represented in this work group. And again, the purpose was to examine the current mobile crisis services and make recommendations for improvements and enhancements. Out of this redesign, or part of this redesign, we implemented a stakeholder survey. So we sent out a survey to various stakeholders, including community partners, our local mental health authorities, and various law enforcement, various stakeholders in the community. To get a sense of what their perceptions were and what their thoughts and recommendations were for how the current mobile crisis system of care was working or not working, and what they thought could be improved. And out of this mobile redesign work group, the Community Wellness and Recovery Coalition was developed, which was also a work group that really was designed to take a look at the recommendations that were made and to try and implement some of those recommendations and enhancements to the crisis system. We also had consultation from the Connecticut Department of Children and Families. We received a lot of technical assistance from the Mental Health Training and Transfer Center, which provided us with a lot of training around best practices. We had meetings with all of our Demas CEOs to get their feedback and thoughts. And we also did agency site visits to the various mobile crisis teams to get a sense of what was actually happening at each organization in their mobile crisis team. As I mentioned on the previous slide, the Wellness Recovery Coalition, the CWRC, comprised a variety of stakeholders, including representation from CCAR, who I see is also on this call this morning, Advocacy Unlimited, which is the peer-run, peer-led organization, leaders from the faith-based community, community organizers and educators, the deputy police chief from the Danbury Police Department. NAMI had a representative on that coalition. The North Central Regional Mental Health Board, now known as Amplify, was represented on that coalition. And we also had private nonprofit and state-operated mobile crisis team clinicians or supervisors representation on that coalition as well. And the focus was on creating a community of care so that people in distress would have quick access to the types of services and supports of their choice, again, emphasizing choice, that would foster optimal post-traumatic healing and growth wherever they may be in their recovery process. And so this coalition began to implement some of the recommendations that came out of the analysis of our mobile crisis system of care. In early 2019, the stakeholder survey that I mentioned that was conducted in partnership with Yale, again, trying to get a sense of what the community partners thought of how mobile crisis services were being provided, and we got information from that. We also spoke with persons in recovery, law enforcement, family members, and others. And we got a really wonderful response of 883 individuals across all 5 Demas regions. So we got a lot of really excellent information and participation in that survey. Out of that survey, the following recommendations were that to increase education and training of our mobile crisis teams and providers in providing best practices related to mobile crisis care, to implement a statewide call center, which, yay, that's what we did. So that, that recommendation was successfully implemented. To establish minimum hours of operation, our current mobile crisis care system, again, the 18 different mobile crisis teams all have different hours of operation. And so that was one of the recommendations that definitely came forth out of this, was that there be at least a standard or consistent hour of operation across the board. That we really needed to enhance our data collection and outcome measures related to mobile crisis and CIT, which we're actually addressing right now, and we're working on that within the Demas Office of the Commissioner. We're looking at data collection and outcome measures. To advance CIT, the crisis intervention team integration into the mobile crisis teams, making sure again that all of our mobile crisis clinicians are trained in CIT, and that the police departments that we work with are trained in CIT and have a CIT coordinator at their police department. Again, looking at and enhancing the prevention and post-vention components, really enhancing and adding to our recovery support specialists and getting more peer involvement. We have some, but definitely not enough. And so we want to really enhance those efforts to get more peer support specialists on our mobile crisis teams, and to really, get up to speed with technology, and really trying to see how we could use more technology in the work that we do, because we really are not where we want to be in terms of the use of technology with our mobile crisis system. So those were some of the recommendations, some of which have been implemented, some of which we're still working on. But these are definitely the areas that we are focusing on for the future work of our work group. Okay. Is this United Way? Is this where you guys start, or is this my last slide?
I think this is your last slide, Dana.
Okay, thank you. I don't have slide numbers on here, so
Yeah.
Thank you. So, so as a result of the recommendation of developing the statewide call center, in November of 2019, Demas released an RFP asking for proposals for organizations to be the provider of this statewide crisis call line, and in December was the application deadline. January of this year, United Way was selected as the provider, given their extensive work with crisis call lines. They certainly have a lot of experience with this. And in April was when we selected the name. We also surveyed the Connecticut Suicide Advisory Board, and got input from the various stakeholders listed here when we were coming up with the name of the action line, making sure that we had various stakeholder input to come up with that name. And then finally, in May of 2020, we started the implementation process, and we had weekly implementation meetings. We continue to have weekly implementation meetings with the United Way and Demas to implement this call center statewide. And as of December 2nd of this month, we have full implementation. We had a staged, kind of a staggered implementation of starting with not all 18 programs at once, but small increments of, and including more and more programs as we went along. And on December 2nd was our final implementation phase. So that's when we are now fully implemented, and are very excited about that process. And you now hear my 3-year-old in the background. So with that, I'm going to turn it over to United Way. Thank you.
Thanks, Dana. And I just want to start by thanking all of our Demas colleagues and all the providers that we've been working with over the last several months. I am going to take my video off just so I can keep my connection going here. So the action line, the Adult Crisis Telephone Intervention and Action Network. So we all know it as Action Line, and that's what we'll be referring it to through the rest of our presentation. We are a centralized adult crisis call center for the Action Line. And in addition to that, we are also the statewide call center for several other programs, including handling calls from the National Suicide Prevention Lifeline. The call center itself is available 24/7, 365 days a year. So that's holidays, weekends, rain, snow, we are there. Interestingly enough, due to the pandemic this year, our entire staff is working remotely at this time. We are available to provide after-hours coverage weekend and holiday for the mobile crisis teams as well. And some of that is after-hours coverage, and we'll talk a little bit more about that in a few minutes. Our staff, our bachelor-level staff, however, we also have clinicians, a licensed clinical social worker, Sarah Camerata. Many of you may already know Sarah, who oversees this program, paraprofessionals, an individual with lived experience is also a member of our team, as well as a supervisor overseeing the call center staff who are handling Action Line calls, including multilingual staff. We do have staff that are multilingual, but we also use a teleinterpreter service. So whatever language an individual speaks, they can call in. If we don't have bilingual staff available or someone who speaks that chosen language, then we will connect with the teleinterpreter service so that we're able to serve the caller in distress. Thanks. If you just don't mind advancing the slide for me.
Yeah, I'm sorry, Wendy, I'm trying to advance and it's not wanting to advance. The beauty of technology.
Sometimes, yeah, it's tricky sometimes, Dana.
Thank you. So we'll talk a little bit about the Action Line goals and whoops.
There we go. That's okay. The next slide. Sorry.
No problem at all. We're all just a little technology here. So the Action Line United Way of Connecticut 211. So again, as I mentioned, we've always been a member of the National Suicide Prevention Lifeline. Up until October 1st, we shared that responsibility for the state of Connecticut with another provider, but on October 1st of this year, we actually took over as the state's National Suicide Prevention Lifeline provider. In doing so, we've actually seen an increase of calls to this line, and we also think that some of this may be attributed to the pandemic as well. We are a provider of mobile crisis intervention services through the phone for the youth program. We actually became the statewide call center for the youth program in 2009, and many of you may have known MCI as EMPS. We also are the statewide call center for the Coordinated Access Network. So this is individuals who are at imminent risk or who have lost their homes or are currently homeless, and we serve as the statewide intake for that process. We also implemented both the youth program and the Coordinated Access Network phased approach. Just as Dana had mentioned a little earlier, we followed the same process as we implemented the adult program as well. The Coordinated Access Network went statewide in January of 2015. We also have extensive database of all our local resources, not only our own database at United Way of Connecticut, which has thousands and thousands of resources and referrals that we can provide to individuals, but also we work closely with the mobile crisis providers during the phased approach and during the implementation to hear some of the resources that they used within their catchment areas as well. United Way, we are accredited by the American Association of Suicidality. That is not only for our agent our agency that we are accredited for that, but also we have individuals on our team that have individual certification for AAS as well. We follow all guidelines established and protocols from the American Association of Suicidology and also from SAMHSA. So it's non-clinical, but there are imminent risk policies. We follow assessment in our intervention, referral, and all of our safety planning that go along with those individual protocols. Dana mentioned earlier for the mobile crisis providers, also go through a debriefing process. United Way of Connecticut and individuals handling calls on the crisis lines for callers in distress also go through a debriefing protocol after those calls as well. Thank you. Next slide. So I wanted to take a moment to give you kind of the process that an individual in distress will go through when they call the action line. United Way of Connecticut 211 is an information and referral and crisis line, and you heard Dana talk a little bit about that, and I'll give you an overview of that too. So we're handling calls that come in through the National Suicide Prevention Lifeline, through the youth program, the Youth Crisis Program, through the Coordinated Access Network program, and now through the Adult Mobile program as well. There's two ways that individuals can reach us, and the slide was shown earlier. An individual can call or dial 211, press option 1, and then option 2. And that will bring them into the action line, where we have action line and crisis staff who are assisting the caller in distress. The other way individuals can reach us is by dialing the 1-800-HOPE-135. And we're going to talk a little bit more about the marketing material around that shortly. That number's out there already, so if an individual calls that, they will come directly into the action line so that that individual in distress can be served by the staff. Our main goal, and this is part of our crisis worker and our prevention work, is really building a rapport with that individual's caller. They have selected a prompt or dialed the 1-800 number, and they are in distress, and they are looking for some help from the individuals on our team. So our main goal is, and our training program is really around building rapport with that individual caller. Throughout the rest of the presentation, and as we talk about this, we really want it to be person-centric and really focusing on the individual. So we're going to determine what's causing their distress. This is a non-clinical assessment. The staff, as we mentioned, are paraprofessionals. We do have licensed clinical social worker and licensed clinical staff that work within our programs. But that non-clinical assessment is we're really trying to determine what the nature of the individual's distress is. We're going to ensure safety planning, and we start that right at the beginning of the call. Is there any imminent risk, danger to themselves or others? And really try to build that in. We don't come out, it's not a script. We're really working with the individual based on how they're communicating with us, but we also want to make sure that they're safe at the point in time that they're calling us. We are going to, one of the things that we can do is if there isn't any, we have protocols in place if the individual is at imminent risk. However, if the individual is not at imminent risk and they're looking for additional support based on their needs, or through the conversation with our staff determine that they would like to speak with someone on the mobile crisis teams, then one of the things that we're going to do is connect that individual with a member of the mobile crisis team. And one of the things for all of the teams that we're working with, we have individual protocols. So although our protocols at the action line are consistent with crisis worker and intervention protocols, we work individually with each of the mobile crisis providers within the community, within their catchment area, based on how they work within their agencies. So we have a standard way of communicating. There are some agencies that will warm transfer that caller to. There's other agencies that we follow up with, and they'll get back to the caller. Our main goal is at the action line is ensuring that we're connecting that individual in distress with a mobile crisis provider. So I won't go into all the protocols that we've established with the individual mobile crisis teams, but they know that every caller that's in distress that contacts the action line will be connected to someone for assistance. We will notify the mobile crisis teams. There are times through our non-clinical assessment where perhaps the individual is going to contact the mobile crisis team on their own, or will provide other referrals to that individual. They may have called in on that line looking for some guidance or some support just at that moment, but they also have, other supports that they're working with already and just needed that moment in time to talk to someone through what was going on and really talk about why they're in distress. So again, I focus back on that person-centric. It's really working with that individual to determine what their needs are, and if the result of that is contacting a mobile crisis team member, we have the protocols in place to do that. If the individual is in such distress that they're not able to assist themselves, then we will work with law enforcement 911, or even if necessary, having someone go out and just check on the individual that's in distress. So again, it's really building that rapport, determining what the caller's needs are, what is causing their distress, and then working with them on a solution, either be mobile crisis or with other referrals within the community. Thanks, Dana. Next slide. So the goal and objectives here, and this is kind of a combination between us and Demas, is really the goal is not to have somebody go to the ED or be admitted to the hospital. It's working with the mobile crisis providers for support for that individual in distress by creating a statewide call center. Along with the other calls that we receive from individual in crisis, it gives us that ability now to have that direct connection to those mobile crisis providers. We've always had this, but this is in a coordinated effort in order to serve that individual. And I mentioned this before, it's really that person-centric. What are those options available to that individual at that point in time? You know, the other here is to prevent incarceration, to increase connection with treatment options and community supports. And some of that will be done through the action line, but it may also, in many cases, be done after we warm transfer that call to the mobile crisis provider as well. And to provide community-based services to support people who are in an emergency or experiencing a crisis at that time, and least restrictive, again, really working with an individual to meet them where they're at and really focus on them, the protocols and the policies and the guidelines that we have at the action line for all our crisis programs, whether a caller's at imminent risk or they need assistance from law enforcement or medical personnel, is to be as least restrictive as possible and really to work with that individual to determine what their needs are. Next slide, please. So then Dana talked a little bit about this, and so did I. It's really, we decided to as an implementation team to phase this in. And you can see we began on August 12th. I'm so excited when we talk about this that we're fully implemented now as of December. But we began in August. The first two providers went live on August 12th, the second two on September 16th, the next group on August 21st, and then most recently, the last group on December 2nd. How we approach this is really taking a look at areas, volumes, and give us some, what Demas and United Way wanted to do as we were implementing this is give us some time as we implemented each phase to work towards, were there any concerns? Was there something that really went well? We wanted to keep moving that through each phase. And we found that we were very successful in that. In the very first phase, there was a lot of work to be done on our implementation team and really working at protocols, and not only for the mobile crisis teams, but for the action line as well. There was a lot of work around marketing and how to connect with 211. So we did a lot of that in the first phase. So then when we moved to phase 2, phase 3, and phase 4, we actually were able to share those experiences in the first phase with the second, the third, and the fourth, and so on, till when we got to December 2nd, as we learned through things through there, we were able to share with each successive phase that we brought in. Next slide, please. So now I want to talk a little bit about key data collection, and Dana mentioned that earlier, that this was one of the goals in implementing the action line and a statewide call center, is really take a look at our data. I will tell you, as we continue to move through each phase, of the implementation, and took a moment to review data, and as we were looking at outcomes and gathering this, we continue to refine this. There's some things that we're currently working on that we're going to be able to provide everybody as we collect this data. So we took a look August 12th through November 30th. So keep in mind, this will not include the phase 4. The last phase, the phase 4 providers just were implemented on December 2nd, but we wanted to at least be able to show you some of the data we've collected to this point. So I mentioned the action line, and you see there the number of calls we handled that came in by dialing 211, by pressing 1, and then option 2. We handled over 14,500 calls on that line. On the National Suicide Prevention Lifeline, again, we became the statewide National Suicide Prevention Lifeline provider on October 1st. And so the August 12th through November 30th does pre and post, and for the same time frame, almost 2,200 calls that have come in on the National Suicide Prevention Lifeline. When we take a look at the number of calls referred to a mobile crisis team, it's going to show 260 there. And the note that we put here is that was only about half of the providers. So it wasn't that we weren't referring to mobile crisis teams, but this is information that we captured of the teams that had already completed phase 1, 2, and 3. And the outcomes we've listed below. And the outcome measures themselves, and I'll just pause a little bit here just to talk to you about the data collection system we're using. It's actually known as iCarol. And one of the things that each time when a caller in distress reaches out to the action line, we go into the database iCarol and enter data for the mobile crisis providers. There's a basic demographic information about the caller, a brief description about what's going on with the caller at the point in time of the call, what's causing their concern or distress, and then we assign that over to an individual on the mobile crisis teams. They are then able to go in and access that record, our complete record from iCarol, and see all of our notes. One of the things that the providers then do is follow up with the outcome of that call. And there's actually 4 outcomes, but I wanted to focus on the 3 that are key for us today. And one is a mobile response with the police. Dana talked a little bit about that earlier, mobile without police. mobile with police, and then a non-mobile telephonic support. So you can see the non-mobile telephonic support right now is a higher response than that with police, without police and with police. So one of the things is when the action line staff assist a caller in distress, the caller may present to the action line staff one way. They may, through that conversation, determine that they want either to speak on the phone with a provider, a clinician, or they may decide that they really need somebody to come out. Once we warm transfer or reach out to that mobile crisis team after their clinical assessment and their conversation, they may determine that there's a different outcome based on that call. So we're doing it, the action line, at the initial point in time the call comes in. However, that could change through the conversation with the mobile crisis teams. Next slide, please. So this is additional information, and I mentioned on that form, on that iCarol form, it's a template form, we do gather caller demographic, and so gender, age, race, ethnicity, date of birth, the language, and were they a veteran, were they homeless, were they disabled? So we can gather a lot of data through that conversation with the individual in distress. Part of the training that we went through with the mobile crisis teams regarding iCarol and our conversations with the callers in distress is sometimes they'll share this information. There are times when they may choose not to. It really depends, and is determined by that individual. We find that a majority of the individuals will share this information. And you can see just in the caller range, it's interesting. When looking at this particular, and this is for the same period, that August 12th through November 30th, that 45 to 54 age range is high, the highest, followed by 25 to 34, and then 35 to 44, 55 to 64, and over 65, very similar in the number of individuals that are speaking with us. So we do gather this information. This is actually some of the information that we're refining based on our conversations with Demas and based on the information that we can collect from the caller in distress. Next slide, please. Now, one of the things that we did, and this is the first time that the action line, the United Way of Connecticut and in implementing the action line call center gathered specific data based on a survey, a satisfaction survey. We've done surveys before. We have surveys that we do for United Way on our information and referral lines. We actually do surveys for our youth program. But this is the first time that United Way, through now the action line, we offered a satisfaction survey to individuals who called on the action line or called in crisis that were in need of services. And what the individual will do is they'll follow the prompts and then they'll receive a survey. They complete the survey. And this was some of our the results of our survey. As you can see, 374 individuals elected to take the survey. One of the things that were being measured, as an action line on are our active listening skills. And that's important because, as I mentioned earlier on in the presentation, one of the things that we want to do as a member of the action line team is really listen, and as a member of the crisis team at 211, is really listen to what the caller's needs are, taking that time to really hear what they're saying, demonstrating empathy. We are very concerned and express that in the call. So we want to build that rapport. We want to listen to what the caller has to say. We want to demonstrate that we're empathetic to the situation that the callers experience. And the call answered in a timely manner. We continue to evaluate that. This is, did the individual taking the survey feel that the action line staff answered the call in a timely manner? Were the right resources provided? Again, this is going to depend on each individual. It's not necessarily this person needs this and this person needs this. It's really going to be for that individual. Did they feel that the right resources were provided to them? Would they be likely to call again to the action line? And then their overall satisfaction. So you can see 5 is strongly agree and 1 is strongly disagree. Our goal is to really be at 4 or above. And, you know, again, we will continue to evaluate this data. We continue to take a look at it. There are sometimes when we receive some of the feedback that is coming in, it could be for some of our, perhaps another program. So we continue to evaluate this data, and this is new to us. This is new, having adults in crisis complete a satisfaction survey. So we're going to continue to gather this data, continue to analyze this data, and really meet our goal each month. Next slide, please. And here's marketing promotional materials. So Dana, I'll ask that we both take a look at this, and Jeanette Baker is actually on the call with us as well. One of the things that we really did is look at, and we did spend quite a bit of team as an implementation team looking at marketing and promotional materials, things that would really be able to be out there, present to a caller in distress. And one of the things that we're working on, or I should say Jeanette and the Demas team are really working on, is brochures, wallet cards, posters, really taking a look at what are going to be some of those items that will get an individual's in distress attention, but maybe a family member, provider in the community. So really taking a look at that marketing material on our implementation team and really determining what would work best. It is available in English and Spanish. Jeanette put her email address and also the United Way of Connecticut website. Materials can be ordered there as well. And what you can see is a little bit of gotta put it in my screen a little bit. I apologize. So you can see some of the presentation. This gentleman on the phone here, we're mentioning both the 1-800 number on it and 211. We want to make sure that that if an individual's in distress, they can call anywhere to get the help they need. And if you scroll down just a little bit for me, Dana, and please, if you have feedback as well, Jeanette, please jump in on this. You can see the logo, really, you have options with the eyes. Again, we're saying what the action line is, what we will do here, what the services that we'll provide, and really how to reach us and when you can reach us. It's free, 24 hours every day, multilingual. We do mention that there is the opportunity to provide feedback as well. Jeanette, did you or Dana want to add anything else to that?
Well, as far as the bilingual, the poster is double-sided, one side English, one side Spanish, as well as the brochure. We feel that this makes it easy. So you pick up one brochure or one poster, and depending on your language, you could just flip it. The wallet card is separate. You know, you can either request, it would be either English or Spanish. That's not double-sided. We're also going to be doing a postcard, similar with the same design that would be available to help people become aware of the program. So they're at the printer now. They will be available on the website for you to request, and United Way of Connecticut will ship them out at no charge for those requesting them, hoping that, you know, in the community, they will help us through a grassroots marketing, get the word out with the materials.
Thanks, Jeanette. And it's the 1-800-HOPE-135 was actually selected with the team, and we list it here as 1-800-HOPE-135, but also spell out what that number is as well. Next slide, please.
Oh, I do want to say thanks to Dana for the logo design.
Yes. Dana worked hard on that, so nice work, Dana.
Thank you.
Next slide, please. And here you can see it goes into the services, what to expect, the team.
Yeah, this is the brochure, Wendy. Sorry to interrupt you, but this is a picture of the brochure.
And so it's really explaining what we do, what the service is, what to expect when you call, the team, how it operates, the MCT services, and the United Way of Connecticut. So this is the brochure, as Dana just mentioned. Next slide. And we took an opportunity here to list all the resources that are available. And I believe that either the presentation or the recording of this will be available, but it lists all the different additional resources that are within the community. Next slide, please. And then it's all of our contact information. And I think it's so important to mention that both Dana and Andrea are on this call, but we've also worked so closely with Nydia and Erica, who also were great partners and colleagues in assisting both myself, Sarah, and Tanya Barrett, our Senior Vice President, in really getting us to where we are today and being fully implemented on December 2nd. So I just wanted to thank all of them as well.